Hello everyone. I'm Dr. Shricharith.shetty from Department of Dermatology. I'll be talking on two topics today, that is viral infections as well as parasitic infections of the skin. Clinically is this type of pearly white papules which are seen in different parts of the skin. It is most easily transmitted by direct skin to skin contact. Mm, Incubation period varies from 2 weeks to 6 months, and typical lesions are discrete, dome shaped, and umbilicated papules. So, this is a picture of similar molluscum lesion in a person who is immunocompromised, that is, a person with HIV. So, here you are seeing multiple lesions all over the face. How do you diagnose this? Direct clinical examination is all that is required. You can just see and make a diagnosis, but if in doubt, what you can do is you can remove the material and stain it and see under microscope. How do you treat? You can just ideally we have to remove it off. One or two lesions are there, means better remove it off either by needling, curettage, or by electrocautery. If it is extensive, you can give certain systemic treatment also, such as levamisole and cimetidine. The next common viral infection that we come across is human papillomavirus, that is warts, what we commonly call as warts. There are more than 100 types of human papillomavirus, but the transmission, how do they get transmitted? They get transmitted by direct contacts. So direct or indirect contacts can be there, which leads to for someone to get these warts. So the other mode of transmission is sexual transmission. So that leads to genital warts or perianal. So, what are the clinical types? The clinical types are non-genital and genital. What we have said, non-genital ones are verruca vulgaris, verruca plana, filiform, digitate, palmoplantar, and periungual wart. Genital is condyloma acuminata. So, common wart is caused by HPV type 1, 2, 4, 27, and 57. These are commonly seen in young children and adults. Also in people who commonly touch meat and immerse their hands in water and other risk factors. Papules with what you see is papules with verrucous surface, very commonly seen on hands, especially on the dorsum aspect of the hand. Verruca plana is a type of wart which is small, which is very small and flat topped, which is seen in face commonly. You can see in the photo near the nose, and there are multiple small lesions. These are verruca plana. Then the same wart can be on the palmar surface of the hands. That is commonly what we call it as palmoplantar warts. The common type, which HPV type, which causes this is 1, 2, 4, and 27. They are commonly seen at pressure points, and if the pairing is done, you may see small black points inside it. Pairing means you just scrape the top surface of the wart. And there is also something called as filiform wart or finger-like digitate wart, which are more protruding like finger-like lesion. And periungual wart is one which is near next to the nail, which is very difficult to treat, commonly seen in nail biters. Genital wart is the wart which is seen in the genital area. Low risk genital HPV types such as 6 and 11. Then there is high risk genital HPV type 16 and 18. Condyloma acuminata we call it as, when genital warts are called as condyloma acuminata, few millimeter to centimeter in size, lobulated papules, usually multifocal, cauliflower-like mass, may be seen in most occluded areas. Lobulated papules, usually multilocal and with occluded areas, and sites are usually intraurethral in men, mucosal surface of the cervix or vulva, perianal and vulva, perianal skin and also the vulva. Giant condyloma acuminata is also called as Bushke-Lowenstein tumor, which is a bigger lesion, so also may lead to verrucous carcinoma, and metastasis to the local lymph node. Boulinoid papulosis, another type where there is hyperpigmented papules or flat surface, that is HPV 16 and 18, again seen in genital areas. This is a clinical picture of genital ward. The genital warts, well, this is the clinical picture. Many cauliflower-like lesions are seen, outgrowth, usually at the. The treatment remains application of salicylic acid, lactic acid, or salicylic acid combination, that is chemical cautery, or using podophyllene TCA of 35 to 85%. Sometimes we also do cryotherapy. Electrocautery and cryosurgery and carbon dioxide laser also can be used. This is a video of electrocautery where we use a probe and just burn the wart. This is one of the method used for treatment of warts. This is cryotherapy where liquid nitrogen is sprayed over the warts. Uh, this is another mode of treatment of warts. The next virus is human herpes virus. There are 8 types of human herpes virus, but what we discuss mainly HSV1 and HSV2. HSV1 is the one which causes herpes labialis and herpetic gingival stomatitis, whereas HSV2 is the one which causes herpes progenitalis and herpetic vulvovaginitis. Herpes simplex infection is mainly involves the skin and mucous surface, can be disseminated in neonates and immunocompromised individuals. What happens? Usually there is 2 episodes here, primary infection and recurrent episodes. Primary infection is the first episode. Primary infection is the first episode which enters into where the virus forms an infection, the patient gets the symptoms, and then it enters into a dormant stage, resides in the sensory ganglia, and can be reactivated at any time. So, more than 90% of the primary infections are subclinical, or you may not even know it, but many times there will be some symptoms associated with it. Mm. So if you see oral labial herpes, 95% is caused by HSV1. Grouped vesicles are seen and with an erythematous base at the angle of the mouth, or which usually seen after an episode of fever or stress, or if you are outdoor activities, you may see such lesions happening in the body. That is often there will be some prodrome of tingling or itching before these lesions appear, and then the vesicles appear, grouped vesicles, then mild flu-like symptoms. Then there is herpetic gingival stomatitis, which will be more severe form of viral involvement with a high fever, irritability, anorexia, mouth pain, and drooling. Symptoms last for 5 to 14 days, but virus can be shed for weeks even after resolution. Differential diagnosis should be aphthous ulcer, Steven-Johnson syndrome, and also diagnosis. We can make a diagnosis of herpes infection by just scraping the base of this freshly ruptured vesicle and staining with Gielsa stain. We look for multinucleated giant cells, and then you can also send for antibody testing or PCR, which is sensitive. Genital herpes, here the infection is usually by herpes simplex virus 2 in majority of the cases, and it spreads by skin to skin contact. Asymptomatic shedding accounts for majority of the problem, whereas the primary infection you may see grouped vesicles which appear in 7 to 14 days of incubation period. Fever, flu-like symptoms, enigma and lymphadenopathy will be there, and recurrent lesion will be typically followed by only more of time. It's just the outbreak of vesicles without much of prodromal feature. Uh, than compared to. So this is a group of vesicles seen at the shaft of penis. Treatment for herpes infection is antivirals. You have to give mainly acyclovir, which is primary. You give 200 mg 5 times day, or 400 mg TID. Recurrence is usually 400 mg TID as a treatment is given. Varicella. Varicella is chickenpox. This is again caused by herpes group of virus, um, which is acute and highly contagious exanthem that occurs most commonly in children. Lesions appear scattered, then clustered, and progress from rose-colored macules to papules, vesicles, pustules, and crust. Individuals are infectious for 4 days before and 5 days after the exanthem appears. Here in varicella, you see multiple vesicles all over the body. Very common disease, and its secondary bacterial infection can occur in this. There can be other systemic complications such as pneumonia, which is seen in adults more commonly, thrombocytopenia, and purpura fulminans. The treatment for this is acyclovir 800 mg 5 times a day for 1 week. And for severe cases and high risk individuals and adults for more than 13 years. In children, we usually don't treat, but severe cases and in high risk individuals and adults, we treat with acyclovir 800 mg 5 times a day for 1 week. Isolation of the affected person is very important, especially from immunocompromised. This is a clinical photo of varicella. Prevention, how can we prevent varicella? We can give a live attenuated virus to kids, so we can prevent it from infection. At present, immunity appears to be lasting, and modified varicella like syndrome can occur after giving the vaccine, which can be mild fever and few macules on the body. Varicella can be problematic if it occurs first time in the pregnancy. If it occurs in the first trimester, then the child can have congenital varicella syndrome, where there will be hypoplastic limbs, scars, ocular and CNS disease. That's in the first time. So these lesions heals without scarring in young, but in elderly it may lead to scarring and increased incidence of scarring in elderly and severe eruption. There can be also something called as disseminated zoster, where there are more than 20 vesicles outside the dermatome. Usually here the lesions are seen in a single line in a dermatomal pattern, but sometimes the vesicles can be more than 20 outside the dermatome. That is called as defined as more than disseminated herpes zoster. It occurs in immunocompromised and especially elderly group of individuals. Herpes zoster ophthalmicus, it is the involvement of the fifth cranial nerve, ophthalmic branch. Here the lesions are seen on the face and the eyes, especially when it is seen at the tip of the nose. It is called as Hutchison sign. And involvement of eye is very common in that case. That is especially uveitis, keratitis, and less common glaucoma, optic neuritis, and this is a photo of herpes zoster ophthalmicus, where lesions are seen in the ophthalmic division of trigeminal nerve. Diagnosis again more of a clinical, but if you want to do some bedside diagnosis, you can do Zank smear. Again, PCR can be sent and antibody testing can be sent. Treatment is same, acyclovir 800 mg 5 times per day here for a week it's given. One of the complications of herpes zoster is post-herpetic neuralgia. That is, there will be intense pain even after the herpes is treated. That heals, herpes lesion heals. There will be intense pain. That is what is called as post-herpetic neuralgia. Constant burning pain, intermittent stabbing pain, or shooting pain, stimulus evoked pain, including allodynia. Treatment for this is capsaicin or topical lidocaine. Oral analgesics can be given. Tricyclic antidepressants can be given. Amitriptyline, anticonvulsants, and gabapentin. Injectables like lidocaine and steroids. That's about the viral infection. Now I will talk brief about two important parasitic diseases called as scabies and pediculosis. Scabies is a very common but highly contagious infestation of skin caused by Sarcoptes scabies. Predominantly a disease of children, it affects people of all races and social classes worldwide. Exact incidence is not known and it has known to be varied from time to time. It has So commonly seen in high humid conditions, low temperature, and infested members in the family or sexual partner. Crowded conditions like jail inmates, hostels, army barracks, where it's very common to see this condition called scabies. Scabies usually scabies usually affect specific areas of skin. Usually, face is not involved by scabies because of the high density of sebum in the face, and also it's not the place for ideal colonization in adults, especially, but in children, face can be involved also. Usually, a healthy patient harbors in around 10 to 12 mites, maximum up to 50, which lives 1 to 2 months in a person, but outside the body, it can survive only for 3 days. It dies if it's exposed to temperature of 50 degrees centigrade for around 10. Transmission is usually from close contacts, person to person contact. Um, Even 15 to 20 minutes of contact is sufficient. Occasionally by fomites, that is bedding, linens, and clothing. In adults, scabies, it can be sexually acquired also, and it cannot be transferred by pets or animals. Uh, the typical scabies, but there are others which are called as animal scabies, where the mites which are there in animals can be transferred to. Clinical features is usually intense itching, predominantly at night. In a daytime, it's tolerable but persistent. In a person who has never had scabies before, the symptoms take around 6 weeks to appear because of sensitivity begins about that period. A person who has been infected already earlier, few millimeter to centimeter or more. Predominantly involves finger webs, wrist, axillae, areola, umbilicus, lower abdomen, genitalia, and buttocks, forming an imaginary circle or circle of Hebra. In adults, usually spares face and scalp. In infants, it involves the entire skin. Clinical types, we have scabies in children, nodular scabies, bullous scabies, scabies in clean, Norwegian scabies, scabies incognito, and animal transmitted scabies. Scabies in children differs in the way that even the face will be not. Nodular scabies, we get more of nodular lesion, and bullous scabies again more of bullous lesion. Scabies in clean is usually very limited with minimal itching, not as severe as the other types. Norwegian scabies is crusted scabies in an immunocompromised individuals. It's very severe form. And other two are rare ones, scabies incognito and animal transmitted scabies. Scabies incognito, you don't see any clinical evidence such as papules and but there is usually the symptoms of itching going on. And animal transmitted scabies, as I discussed, it's usually transmitted from. This is Norwegian scabies, this is nodular scabies. This is scabies, one of the complications where it gets infected with bacterial infection, so it is secondary infection. So how do you go about? We don't need any specific investigation to prove it. Usually clinical signs are more classical. In some cases, we may have to demonstrate the organism. We can take a scraping from the burrow and demonstrate the egg, scibilla, or mite under the microscope. So this is how a mite looks, and this is how the feces, that's scibilla, looks. So treatment, very important to advise proper treatment to the patient. It's usually a blanket treatment where the patient along with the members staying in the family is treated. Topicals which we prescribe are usually applied below neck in the whole body at night time, and it's washed off the next day. All the clothes worn along with the bedsheet, pillow cover, and bed linen should be washed and sun dried. And treatment is not exceeded, should not exceed the prescribed limit. For example, permethrin, if you give 5%, it's usually used once in the night, and again it is repeated after 1 week. This is the one which we commonly use, most commonly, and it's whereas the other one is gamma-benzyl hexafluoride, that is lindane, which is 1%. It is effective and safe with proper application, gives a cure rate of 89%, In infants and children, application should be restricted only to 2 hours. Repeat application is after 1 week, and pregnancy it's a category B. Systemically, we give ivermectin, which is used in the dose of 200 microgram per kg. Again, 2 weeks apart, we give two. Always give antihistamines, emollients, and topical steroids only in nodular lesions. Otherwise, don't use topical steroids in scabies. Prevention and control is very important, such as simultaneous treatment with contact, cleaning the beds. Those things are more important along with the treatment in scabies. So the next infection is pediculosis. This is the infestation of humans with lice. There are 3 types. That is basically pediculosis humanus capitis, which causes head loss, pediculosis humanus corporis, which causes body loss, and thyris pubis, which causes pubic loss, which is also called as pubic loss. So the pediculosis capitis caused by head loss. The other name is pediculosis humanus capitis. Pediculosis corporis caused by body loss, that is pediculosis humanus corporis. And thyris pubis, which causes crab loss. Head loss usually have been seen in scalp hair, commonly in children 3 to 11 years. Head-to-head contact, sharing combs and brushes and hats are the predisposing factors. Body loss are seen in clothes, mainly seams, poor hygiene and unsanitary condition, whereas pubic loss is a sexually transmitted infection usually, and it is seen in pubic hairs or axillary hairs, also in scalp and eyebrows and eyelash. Clinical features of pediculosis capitis is usually itching as scabies, and there will be erythema and intensely pruritic papules. In the scalp, when you see, there will be a lot of nits, which may be confused with dandruff. Favorite site is behind the ears, and cervical lymph nodes will be enlarged, especially in children. Pediculus corporis again is itchy papules and excoriation. It's also called as vagabond's disease. Pediculosis pubis is the lice and nits seen by the patient or family members. It's attached to the base of the hair and macula cerulae. Macula cerulae, that is slate-colored macules, are seen on the thigh. So this is the clinical picture of pediculosis capitis. Lot of nits on the hair shaft, and also a lot of itchy conditions on the itchy lesions on the trunk. Treatment again, we use permethrin here, which is, but the percentage is 1% in the lotion form we use. We keep it for a period of 8 to 10 hours and rinse it in case of and remove it in case of lotion. Repeat it after 7 days. The same dose of ivermectin 200 microgram per kg can be used. For pediculosis corporis, only washing and rinsing all the cloths in hot water followed by hot ironing the seams is what is most important required. Repeated application of petrolatum to the eyelashes and eyebrow can remove the lice. Contact should be checked and treated. Combs, hairbrush, and clothes should be shared. So that's about the infestations of parasitic infestation and also the viral infections. Thank you very much.